Hello, and welcome back to another episode of the Empowered Hormones podcast. I'm your host, Sheridan Decker, and I'm so excited to be here today. I know I say that every week, but I love chatting about IBS. I just think it's one of the most underrated areas, an underrated topic, and under talked about topics on the internet, in the world, among health conscious, active women. And today in episode 201, we're chatting about IBS and IBD. So what's the difference and how do I test? Because a lot of women actually have been given the label of IBS and then some have been given the label of IBD. So Crohn's, ulcerative colitis, they're kind of the two we're touching on today. And a lot of women just have the crossover gut symptoms and don't actually know what one they have. So the bloating, the constipation, the loose stools, these are actually all really common in both conditions, but it's really hard to identify what one you've got when you don't actually know what you're looking for and you don't know what testing you should or shouldn't be doing, and your GP is not actually testing for all the things that you need to be tested for. So it is quite confusing, and trying to get a diagnosis or an answer for what's going on with your gut is something that a lot of women spend their whole lives doing. Now, today we're chatting about IBD, which is inflammatory bowel disease. So this is actually a structural inflammatory condition. It, like I said earlier, includes things like Crohn's and ulcerative colitis. Now, with inflammatory bowel disease, it's not something you want. Absolutely not. But it is an autoimmune inflammatory condition. So if you do have it, and the difference between this and IBS is that you can put IBD into remission, say like endometriosis, rheumatoid arthritis. I'll get my words out today. What else am I thinking? Hashimoto's, psoriasis. So all these inflammatory conditions, eczema is another really common one. We can put them into remission, but you still have the disease in your system, for better use of words, okay? But you may not have active flares. You will go into an active flare when either you get really sick, you get really stressed, something else happens in your gut and your life. That's usually when the flare comes up and out. Whereas IBS is a syndrome, so irritable bowel syndrome. So this is not a condition in the way IBD is. It's a symptom label. So it just means your bowel is behaving irritably. We've ruled out the obvious serious stuff, so the IBD things will run through, but that is your entire diagnosis. Two very, very different things. It's kind of like PCOS and endometriosis to a degree. Like PCOS is, there's different types of PCOS. So it might be adrenal, it might be post-pill, it might be inflammatory, it might be insulin resistance PCOS. But it's a syndrome as opposed to endometriosis, which is a diagnosed autoimmune condition. So very different things. PCOS, again, you can basically heal it. You can manage it with diet, exercise, those kinds of things. If it's post-pill or adrenal, you can actually heal it, overcome it, not get it back again. Endometriosis, you're managing, supporting, healing your estrogen detoxing and your immune system long term. So IBD, IBS, what are we talking about? How do we compare them? How do I know if I have them? So with IBD, this is a structural inflammatory condition. So it includes Crohn's, ulcerative colitis. Now, with Crohn's, you get inflammation anywhere along the digestive tract. So this can be mouth right down to your butt, basically. It tends to be patchy, inflamed bits, normal bits, just a lot of that inflammation, which kind of describes what it is. With ulcerative colitis, the inflammation is in the large intestine, so in your colon, and it's continuous. So no gaps, just like inflammation along the whole colon. When these things get serious, this is when you start looking at steroids as a management for it, or long-term stuff. You may actually need to go into surgery for some women and get parts of the colon removed, or you're on long-term immunosuppressants. So this is really, really important to be working with a gastroenterologist with if you have a diagnosis for it. Now, The difference is with both of these, your immune system is attacking your own gut tissue. This is not a sensitivity. This is not a food intolerance. This is structural damage happening in real time, okay? So you need proper testing to rule this out. The gold standard is your colonoscopy with a biopsy. This is how you confirm IBD. But before we get to that point, we can pick up this stuff. So you can pick up whether you're heading towards IBD or whether you may potentially have it. The 3 main tests I run before colonoscopy. So we like to look at fecal calprotectin. So this is a marker, a stool marker for intestinal inflammation. It just tells us basically how much inflammation is happening in the gut lining. If you have normal calprotectin but gut symptoms, I tend to say, well, that's most likely going to be IBS. If you have a little bit of elevated calprotectin and we're pairing that, remember, with a full microbiome test in my testing, not in your GP testing, if you have a slightly elevated, then usually I can see reasons for it. There's parasites, there's bacteria, there's yeast. They are raising the calprotectin, okay? Your GP will not do further testing until your calprotectin is over 80. So the range is about like 0 to 80 is kind of when they will start looking at it. In a bit of a flare, it might be 200, 300, 400. In a real active Crohn's IBD case, I'm looking at them in the thousands, just to give you perspective, okay? So if you come into my clinic, you run a microbiome test and there's a bit of elevated calprotectin, I am not thinking IBD straight away. I will only refer you to a gastroenterologist when it's out of the medical range for sure, just to rule anything out. But 9 times out of 10, you will come back negative for IBD, but still have raised inflammatory markers. And this is because you have a dysbiosis happening in your gut. So your GP, back to IBD, your GP will run fecal calprotectin and probably tell you it's normal. They'll run CRP and ESR, which are standard inflammatory blood markers, not gut specific, but this alongside gut symptoms, alongside calprotectin, we're thinking IBD. On top of that, a full blood count, because anemia is really common in IBD due to chronic blood loss or malabsorption. Both of these, the full blood count and the raised inflammatory markers, can still be true in an IBS case. Fecal calprotectin can all be true in an IBS case, and you not necessarily have IBD. The only time we know 100% if you have IBD is when you do that colonoscopy with the biopsy. And this is why a lot of GPs will run these 3 tests and then they will run your colonoscopy. They are doing their due diligence. They are doing the right thing. The issue is this IBD, if you don't get a diagnosis for it, then you're given IBS and then you don't know what to do. So if you come back with no IBD, then you're stuck. If you come back with IBD, you still have to approach it from a functional point of view. So if you have a Crohn's or ulcerative colitis condition, from a functional perspective, the things that I'm doing is I'm still running a functional microbiome test. You don't then just go down the medical route. So whether you have a diagnosis or not, it doesn't matter to me. I still want to run a functional stool test. I still want to look at what are your levels of your anti-inflammatory bacteria. So we need to restore that good microbiome. What is our intestinal permeability? Do we have leaky gut lining? And is this fueling an immune reaction? What is the immune and inflammatory load? So what food triggers do I have? Not as a cure, but as a way to reduce the burden on an already inflamed system. What are my nutritional deficiencies? So IBD can cause malabsorption. So we see this with low iron, B12, zinc, D, magnesium. We need to test and address all of these. And what is my stress and how healthy is my nervous system? So This gut-brain axis, this is really, really important because chronic nervous system dysregulation, that's going to impact gut motility, mucosal immunity, healing, microbiome composition, right? So in an IBD case, we still need to use a functional approach, look at nutrition, look at the gut microbiome, look at the immune system. If it's negative and we got IBS and we know your bowel's just behaving irritably, that in itself is when I see most women get stuck. And this is where the problem classically starts. You've seen your GP, you've had your colonoscopy, there's no Crohn's, there's no colitis, you got a clear result, you have IBS, now what? Eat more fiber, take a laxative, manage your stress, low FODMAP diet, okay? So you're kind of left with nothing. Like in some cases, women say to me, it's the same with endometriosis. Like, Sheridan, I just wanted a diagnosis so that I knew what I was like dealing with. And I completely get that. Like, I was that person. I was bloated constantly. I had diarrhea. I had constipation. I had food intolerances. I was eating well. I was exercising, right? And I go to the GP, they rule out Crohn's and colitis, and they're like, well, it's just IBS. Your colonoscopy is fine. Your endoscopy is fine. There's no immune markers raised. Your protection's fine. And it's like, well, then why do I have all these symptoms? If I don't have a disease, why do I have so many symptoms? And the thing is, no one was testing for bacterial overgrowth. No one's looking at stomach acid. No one's looking at parasites. No one's mapping out my good flora and my microbiome. So ruling out IBD is really important, but it's only one step. It's not the whole investigation. And most GP clinics, this is the only step that they do, and then they send you home with that label. Whereas you need the next step. You need to either go, I've got IBD, I still need to run a functional microbiome approach and do that alongside the medical system, or I've got IBS, now what? Now I need to be doing a lactulose intestinal permeability test, so looking at SIBO, and I need to be running a comprehensive stool test, so a GI map or cobiome, to look at why you have all these inflammatory markers, like why you have these gut symptoms, why your gut isn't digesting the way it should be. So the two main root causes I see of IBS, and to be fair, they also link back into IBD, because when it's gotten to a disease point, it means either you've had these symptoms for so long that the immune system's now activated, whereas IBS almost feels like the step prior to that. But often both of these conditions will have a small intestinal bacterial overgrowth, so the bacteria that are fermenting the food and producing gas, and that gas is what's causing the bloating, distension, pain, diarrhea, or in some cases, they've got the methane, so the intestinal methogen overgrowth, which is slowing motility. You're getting the severe constipation. You're looking 6 months pregnant. You can go days without a bowel movement. But here's the catch. These two do not show up on a colonoscopy. They are not visible. And this is really common with parasites as well. So these are more common than people realize. They're just picked up through food, water, travel, contact with animals, and they're not tested for in a standard colonoscopy. You need a PCR-based stool test to identify them properly, and not just a basic GP one. You need a comprehensive stool test. The other thing that we classically see in these IBS and IBD cases is this dysbiosis. So essentially an imbalance in your gut microbiome. So not an overgrowth. This is more what's happening in your large intestine. We just don't see a good ratio of beneficial to opportunistic bacteria. Again, both cases, IBD and IBS, have this, and we need to restore it in both cases. But the difference in IBD is we've got that chronic immune-driven component as well. I often see secretory IgA, so a marker you would have seen in microbiome testing, which is your gut's immune defense, is low in IBS cases, whereas it's super high in IBD because it's really overactive immune system. Like any autoimmune condition, the body's attacking itself, right? Whereas in an IBS case, we see this lowered because stress is something that will lower it long term. Dysbiosis drives inflammation. So it doesn't only just impact your immune, impacts your mood, your energy, your skin. Again, isn't visible on a colonoscopy. You need comprehensive microbiome mapping. So a GP's colonoscopy rules out structural damage to the bowel wall. So that's really important to know, but it doesn't tell us bacteria, parasites, stomach acid, or anything about your microbiome. Now, I see this day to day with clients, and I see women who've had gut issues for 10, 20, 30 years. They have been ruled out by IBD, they've been diagnosed with IBS, and then they've gotten stuck on low FODMAP, okay? By the time they get to me, their food list is small, they're still bloated, they're exhausted, they're in a lot of pain. These women, which are you, feel like they have tried everything, and this is just their life now. Until we run a lactulose breath test, a comprehensive PCR stool test. And that is when you're going to get answers, okay? So that's when you're going to know, okay, I've got hydrogen dominant SIBO, or I've got methane in my small or large intestine. I've got blasto. These things get overlooked for years and years and years. And the same thing every single female says is, why did no one test for this? Why did no one say this is possible? So I just want to recap because we've covered a lot of stuff there. There's IBD, irritable bowel disease. There's IBS, irritable bowel syndrome. One's a syndrome, one's a diagnosable disease. One gets picked up in the medical world, one gets labeled as IBS, and there's no answers for it, okay? Both need full blood work. Both need comprehensive microbiome testing. Both really just get a colonoscopy and rule out that anything's going on. Now, before we end today's episode, I want to give you 3 things you can do right now because I want to leave you with something actionable you can do when you are dealing with your gut, with your GP, and you're trying to get some form of diagnosis. When you go back to your GP, don't just ask for testing, ask specifically. If you can, ask for a lactulose breath test for SIBO. Ask for a PCR-based stool test. Now, the SIBO test should be pretty similar to what I would run, but the PCR stool test is not going to be the same, but it will rule out IBD, which would be really helpful for you. Also, ask for H. pylori breath test. It's one you can do with your GP, and this is just going to rule out any nasty bacteria in that stomach. So some GPs will order these, but you do need to ask for them specifically. 2, support your stomach acid before meals, okay? Low stomach acid is so common in women with IBS, and it generally will just make everything worse. It'll exacerbate your overgrowth, limit digestion, cause the bloating to flare. Digestive bitters are great as well, but you can also do a tablespoon of apple cider vinegar and a small amount of water, which will just help, especially in the morning, like warm water. It'll help stimulate the body's own sort of acid production and tell your digestive system basically to get ready to do its job. Not a root cause, is very supportive for all your IBS and symptoms. And 3, please learn to space out your meals. Try and give 3 hours between meals. I know I've talked about this a lot lately, but I am a grazer. I will put my hand up for that. And I do eat quite regularly, but 3 hours is great because it allows your migrating motor complex time to do its job properly and actually clear bacteria and things through your digestive tract. So here's what I want you to take away from today. IBS, not a diagnosis. It's a bullshit diagnosis if you're being told that's what you've got. It's just a label you get when you're ruled out from IBD. So you really need to keep digging to get clarity as to what is causing your symptoms, whether it's SIBO, methane, parasites, H. pylori, dysbiosis, nervous system dysregulation, hormones. These are all treatable, healable, but they will not show up in a colonoscopy or your standard GP medical testing or your standard GP stool testing. IBD, you need to get it checked for. If you have it, you've got to work alongside a functional practitioner and your gastroenterologist to stay on top of it. I think it's important to do both. I appreciate the work the medical system does, and it's important to understand, diagnose these things, and also to manage them long term. But we still want to run a microbiome test. We still want to run functional blood work, and we really want to get to the root cause of what is driving your inflammatory condition, support it, heal it, nourish it, rebuild that mucosal lining, and get those inflammatory markers down so that you don't get to a point where you have to stay on steroids or immunosuppressants long term. So if this is you, you've been labelled with either IBD or IBS, you aren't sure on your root cause, you aren't sure on what drove it, and you really want to heal and support your body naturally, then this is the right place for you. So make sure you book your free gut health planning call. The link's in the show notes. It's 30 minutes. It's free. It's basically the conversation between you and me that your GP didn't have with you. So I want to look at your full picture, your history, your genetics, your family history, what testing you've done, and just map out what you still need to do, what pieces are missed, and where to go from there. So thank you so much for being here. It was a pleasure to chat to you guys, and hopefully this helps shed a bit of clarity on the IBS-IBD mismatch.